Thank you, Dr. Irvine. Thank you for inviting me. It's nice to see some familiar faces in the audience. I have been a risk manager for over 17 years. I started in med-mal, did med-mal for 10 years, then went to academic medicine, then went to hospital risk, and then finally ambulatory risk at Whittier Hospital. I have a special love for physicians. My job is to keep you safe, your license safe, of course patients and risk to the group, but my main focus is to keep physicians safe and to help them practice safe medicine, and that's what we're going to talk about this morning. Let's start with the basics, since I don't know where all of you are from, but the basics for healthcare risk management is to protect the providers and the employees, give them enough information to practice safe medicine and stay safe and keep their patients safe, and really to manage the differences between what the patients think you should be doing and what you know you should be doing for the patients. I like to keep it simple, the 4 C's of risk management, compassion, and we're going to hit on that pretty strongly because you have interesting patients in ophthalmology. Communication, what you say, competence, what you do, and charting, which is going to speak for you, and the importance of documentation. I know you hear that constantly, what you document. Well, we really are going to hit home pretty strong on that. We start off with how you advocate for your patients and what patients expect in medicine nowadays. Patients really expect you to understand their insurance and to remove whatever obstacles their insurance are placing between what you need for them to get, procedures, surgery, medication, and what their insurance is allowing them to get. You are the final decision maker in what you think your patient should have. And you're responsible to advocate for your patients. I'm not saying you need to do everything for your patient, but you should definitely let them know what you are doing for them and to involve them in the process. I always advise the physician, if you're writing a letter to their insurance, to CC the patient, let the patient know, but also advise the patient, this is your insurance, you chose this insurance, so this is what you have to do, along with me, to get that surgery or procedure or medication that you need. So patients expect you to advocate for them, and I'm sure that's what you feel you need to do as well. And it's also, it's doing the right thing. You know, Blue Cross isn't always our friend, Medi-Cal isn't always our friend, but your patients expect that somehow you can move mountains and make magic. Healthcare is it has to be an unbroken circle. And what do I mean by that? So if you're going to perform a test or a surgery and order this, the next step has to happen. You need to review the results that come in, and then you need to communicate the results to the patient. We had a case at another university that is not blue and gold, and the patient kept complaining of chest pain, and had x-rays, and the physician maybe was a little too busy and kept saying, I don't know why you're having this chest pain. And God bless the medical students, because the medical student assigned to that patient sat down and started going page by page on the electronic medical record back to the original chest x-ray, where the radiologist saw a piece of a guide wire still there, causing chest pain to this young patient. And the radiologist report specifically said, follow up. And no one saw this except this medical student. And fast forward lawsuit, fast forward check that we wrote. So make sure that if the test was important enough for you to order, make sure you review it and then make sure you call the patient and tell them the results. And the reason why this slide is here is not because everybody does this. So, and here we go. Are you testifying that you never saw the abnormal test result, the one that you ordered? And we see this over and over and over again. So my advice to you, and I am not going to tell you how to practice medicine, but I've been doing this long enough to let you know that I'm going to advise you on how to stay safe, which is follow the patient complaints to the full diagnosis, prepare yourself mentally before the procedure or the surgery that you're doing, and know when it's time to consult with a colleague or make a referral, because your competency is here and your patient needs this, and swallow whatever ego you have or what's keeping you from saying, you know what, I need to refer you to my colleague to do the next procedure or for a consult, because I'm at the limit to where I can actually help you. So, like we talked about on the first slide, patients perceive what you're doing a certain way, and we have to manage their expectations. So what do patients expect? Well, through the years and lawsuits and depositions, et cetera, we've learned that patients expect that you're going to listen to them, you're going to take what they're saying seriously, and that they are going to be a respected care partner in their care and treatment with you. They want the truth all the time. And unfortunately, some of your patients show up having already gone on the internet, and they know what you should be doing for them, whether it's true or not. Have their care timely. And sometimes what that means is that they're not sitting in the exam room for 45 minutes till you come in. Make sure that everything's well documented, that you're supporting them emotionally as well as physically, and we'll get into that in a couple more slides. And of course, to always receive the highest quality and safe care. When things go wrong, and they will, if you've been in practice a certain amount of years, expect to have a lawsuit. It's not if, it's when. And you need to be prepared. So what are we seeing in the lawsuits that we're getting on our desk as risk managers? And Howard, of course, will go into this as well. But patients will allege that you did not perform the surgery correctly. And we're talking about things that don't end well. So you can do a surgery perfectly, and you can not have a perfect result. Does it mean that there was malpractice? Well, no, of course not, but that's what your patient thinks. So errors or delay in diagnosis leading to a bad outcome, whether it's taking too long to get to a diagnosis, you're not listening to the patient's complaints, and it ends up to be a bad outcome because of those delays. Failure to supervise or monitor care, this is usually lab results or, in your case, testing. Medication errors, we don't see that as often as we used to. But we do see them. Now there's all these great apps that you can have on your phone, and if you do make a medication error, it's pretty far and few between. And failure to refer timely, and we do see that. We have a lot of cases where the patients do have a bad outcome and they don't sue their doctor. Why? Well, it's because they've had a good relationship with the physician up until and including the bad outcome. If you've always had good communication with the patient and or their family, you've answered their questions, you've returned phone calls, and then there's a bad outcome, and trusting that, and I'm trusting, that the consent that you had the patient signed would have included what could happen, those patients don't normally sue their physicians. And unfortunately, if you work for a big academic medical center, some of the patients believe that they're not, if they sue you, they're not suing you personally, because UCLA has deep pockets. Oh, I didn't mean to sue you. I'm suing UCLA. and patients don't understand that concept. But chances are, if you have a good relationship with your patient and you've been available and they've gotten their questions answered and they trust you and they can count on you and your team, let's include your team as well, chances are they would probably not sue you. And here's the question you never want to hear. Dan Gross-Kruger is an attorney who's also a risk manager. He's worked at Stanford as well, and this drives home better than anything I could really tell you in a bunch of slides, which is, when does your patient feel more comfortable talking to an attorney than to you? So when there's a bad outcome, let's start with what not to do. Don't avoid the patient or the family. They're looking for your guidance, answers, and support, and they trust you. And they've trusted you up until this point. Don't blame others. As a nurse, don't throw me under the bus. Well, the nurse, she was supposed to do this and she didn't do that. Don't throw me under the bus. And don't try and fill in the gaps. What you need to say to the patient is, here's what we know now. And as more answers come, I will sit down and I will explain those to you. But this is what we think happened now. Don't use negligent terms about your partner or your fellow or your residents, and don't ignore the situation. If your patient ends up in the ICU, you better be there talking to the patient and their family. And be vigilant and be responsible. Do the right thing always, as hard as it may seem. This is so important. So don't fill in those blanks. The wisest thing a prudent doctor can do when he doesn't know what he's talking about is to be silent. Because patients are going to remember every word you said. And that is going to come up in deposition. So sit down, spend the time, tell them, always preface it. This is what I know happened. And if you covered it on the consent like I hope you did, remember we talked about this when we talked about your surgery, that this could happen. So this is what's happened, and this is what we're going to do now. So what should you do and what should you say? Depending on where you're working, obviously, report to the appropriate people. And in my experience, the second call is usually to your risk manager. Get control, take some time to gather your thoughts. We used to tell the physician, grab the medical record, find a quiet room, sit down, and go through your notes. Well, now you have, chances are, the electronic medical record, but that quiet time to steady yourself and quiet your thoughts that are screaming, and every nerve ending is at edge, you need that time to regroup. Empathize with the family, listen. We used to have an orthopedic surgeon that when he had to give bad news to the patient or the family, and I can't walk away from here, but he would stand at the doorway and lean his hand and talk to the patient and the family from the doorway. You need to sit down, be eye level, make eye contact, let them know that you cared about what happened. You're very sorry, and we'll talk about that in a couple minutes. And again, let them ask their questions, answer honestly what you can, and promise them that you will be in touch, and if they have any more questions, to go ahead and call you. If you're not good at that, and some physicians, by self-admission, will say, I can't do that. They're hard people to talk to. There's 20 of them in that room. Take someone with you. Take your risk manager with you. Take a peer with you. Take one of the nurses with you who you know it has been working with the family. I like to have a second person there so that when patients, if it ends up that they go to the attorney and say you said this, well, you had someone with you as well. Disclosure is the biggest buzzword and the hottest topic now in healthcare, one of the hottest topics. But it's expected, right, that you be transparent, the other buzzword. And so patients expect it, and they have a right, and I agree with them as a risk manager, to know what happened to them. It is a technique and a good communication skill to have under your belt. Like I said, it doesn't come easy to everyone. Sometimes, depending on where you work, they'll actually have workshops where they videotape you, so you can see what your body language is saying, what your eye contact is, and what your voice sounds like. And patients are getting really savvy about knowing when you don't mean what you say, or if you're trying to pull something over on them. So they really expect you to say, this is what happened, and accept responsibility if it was an error on your part. And we're lucky to live in California. You can say, I am so sorry this happened. And it's not misconstrued as you accepting blame for the results of this procedure or surgery. So there's a bunch of other states. I don't know if you're all from California, but here we do have apology laws. And however, I would advise you to say, I am so sorry this happened. Not, I am so sorry that I perfed your intestines. I am so sorry this happened. And then follow it up with, here's what we're going to do from this point forward. And when you lay that all out, do you have any questions that I can help you with? I don't know how many of you have busy clinics and run behind schedule. And let me tell you, that is the first thing that sends patients to Yelp, to any of the online communication, what they're going to say on their patient satisfaction surveys, if your organization uses that. But when they have to wait, after they get checked in and they're sitting in that exam room and they're waiting for you and looking all around and watching their watch and wondering why your time is a lot more important than theirs, you better come in, apologize for being late. I am so sorry you waited, acknowledge it, and move on. So acknowledge their wait, apologize for it, and move on. But hopefully your team in front, when you're starting to run behind, and the magic number is 20 minutes, it used to be 30, the magic number now is 20 minutes, your staff better be going out to Mrs. Minovitz and saying, Dr. Irvine is running a little bit late. We did have an emergency. We know you're here. I'm so sorry. Can I get you some water? Would you like to give me your cell phone and you go down to the coffee shop? But acknowledge that that patient is waiting, and we know you're waiting, and we're sorry that you're waiting. You are not the only ophthalmologist in town. I can throw a rock in Pasadena and probably hit a dozen more. So your patient can do the same thing. You want more people coming in the front door than leaving before being seen at your door. So what should keep you up at night? Risk managers never sleep. Why should you, right? So a surgical complication resulting in reduced or distorted vision, which was a complication and a result that your patient, trust me, was not prepared for, not ready for, and is certainly not happy about. Patient dissatisfaction, big key. When patients are happy, maybe they'll tell their wife or their best friend. When the patients are unhappy, they tell everyone. And the ones that just leave and are very quiet about it are the hardest ones to deal with, okay, that you never see again in your office. Failure to treat or properly refer, we talked about that. Dilating eye drops. I have it in parentheses, risky, because what we're seeing is poor communication to the patient when they come in for their appointment and they don't know you're going to dilate their eyes. Okay? Limited examinations, and what we all love in risk management is the non-compliant patients and the non-adherent patients, because it always ends badly. The question is always, when do I dismiss that patient from my practice? So it's an ongoing conversation that crosses all specialties, not just yours. Where do we see most claims occurring? And maybe Howard could correct me if I'm wrong, but the majority come from hospital, and about 38% are coming from the practitioners' offices. But as you start doing more and more in the ambulatory setting, we expect to see some of those numbers start to change. But right now, most of the claims that we see are coming from a hospital setting. I want to talk a little bit about your patients. I did spend 5 years at USC. I did have a very close relationship with ophthalmology there because your patients sometimes are insane. And the reason I say that is not because they are, but because of things that happen in ophthalmology. And it has everything to do with when you're in fear of losing your eyesight, or your eyesight is diminishing, and how that translates to your life. And I think as a practitioner, you need to be more empathetic than when you say, we can't save the sight in your left eye, what that translates to the real world for your patients. And your team needs to pull the wagons around that patient and help them. I was called over there for patients who were out of control minimum a dozen times. And when I finally got them settled down, one son was actually throwing furniture because he couldn't get someone to explain to his mother softly, nicely, empathetically, why she was going blind. And he just didn't know what to do. I probably wouldn't pick up a chair and throw it, but he did because he was so frustrated. So I need you, especially in your specialty, to understand the implication of the things that you do and the things that you say to your patients when it comes to their eyesight. So the good news is you get sued probably about every 14 years. If you're not doing any surgery or laser, it goes to every 33 years. But if you do refractive retinal or vitreous or anything specialty, that goes down to every 11 years. Now, these numbers are from PIAA, the Physicians Insured Association of America, where many malpractice carriers contribute their claims data, and then we're able to get this type of information back. So that's the average. Obviously, it could be more, it could be less. Los Angeles, I don't have specific to even California, but this is across the country. As compared to a orthopedic surgeon who does spine and gets sued every 2.1 years. So you should feel better with the 14, 33, and 11. And psychiatrists get sued once every 50 years. So physicians, however, feel that any claim that they get, even one without payment, is just as disturbing as one with. So you get a notice of intent that a patient's going to sue you right away. Most physicians that I know run to the medical record because they don't remember the patient, and then they call their malpractice carrier or the risk manager. And the ones that we can make go away is still disturbing. It shakes your confidence, and typically what we see is the first claim you get, the second one comes right behind it. Because you're shaking, you're not sure now, you're going to over-test or you're going to under-test. You're not going to stay the straight road that you normally are able to do, because now you're doubting what you could do, and other people tend to find out about it. And especially if it's a big case at your practice or at your organization or at your academic medical center, and if it goes public, because sometimes these do, you feel that everybody's watching you and everybody's judging you when you're in surgery. We do have special therapists available to physicians to help get them straight again. And it's important. It's important to talk to someone, your wife, don't talk to anyone else, but your wife or your partner or your risk manager, because it's protected, and of course your attorney. But you need to be very self-aware of what this is doing to you as a person, because you need to maintain your work-life balance. And if this starts to spill over into your personal life, into your marriage, into your caring for your children, it's very important that you right yourself up again. So malpractice suits often result when you get an unexpected adverse outcome and the patient is not feeling that you're caring about what happened to them, you're too busy to return their calls, or they think you're holding something back. That's the first thing they think. You're not telling me everything. What really happened in surgery? Let's talk about consent. Everybody gets signed consent for procedures and surgery? Yes, 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 yes. For those of the people in the audience that know me, their hand went right up. So consent, in some instances, and Howard will be able to speak to this, will save your butt. Because when a patient goes to their attorney and says, if I would have known that I was going to lose the sight in my left eye, I never would have allowed Dr. Irvine to operate on me. And Dr. Irvine, having had Randie Minovitz as his risk manager, had a good, tight, and secure consent in the record, including his conversation, the consent conversation, before surgery that he had with the patient and his wife in his office. That's also documented. So the law recognizes that consent is the actual discussion that you've had with the patient. The paper consent with a copy to the patient is just an extra layer of security. But remember, the consent discussion is the consent. So it doesn't, like I said, it doesn't take the place of the discussion. Use words, terms, and diagrams that a patient can understand. Even if you take a piece of blank paper and draw an eye, and then put lines and arrows, that's something that a patient can understand. Don't ever say that the procedure is routine and simple, because you know it's going to happen, right? And don't say there's no complications, because you know it's going to happen. And don't say, if you were my mother, I would definitely go ahead and do this surgery. Keep that out of your conversation. A well-documented informed consent is a great deterrent, especially if your consents are specific to the procedure that you're doing. If you're using a general consent to treat, I would advise you not to do that. But get a consent specific to the procedure or surgery that you're doing, because the patient will have a copy of that and he will have that at home. If you don't give the patient a copy, it's doing them no good. It's in their medical record. It's not in their hand at home for them to read again and again and again and speak to their wife about and show their children and show their son who's a law student, right? But just as important is informed refusal. How many of you have had patients where you've spent all this time talking with them, advising them that this is the best procedure for them, and they go, no? How many of you have had that? Okay, what do? Do you just say, okay? Do you say, I'm not the doctor for you anymore? This is the care and treatment. I think that would be best for you. If you're not willing to do that, maybe I'm not the right doctor for you. Have any of you done that? It's perfectly acceptable to do that. But an informed refusal is just as important as an informed consent, because on that consent for the procedure that you think your patient should have, the patient has to mark, I understand everything my physician said, I'm choosing not to have this procedure, and they sign and date it. And sometimes when you put that in front of them, the black and white of it startles them into rethinking. But even if it doesn't, sign it, give them a copy, put it in the medical record. Let me tell you how important this is. Long ago when I was in Med-Mal, we had a patient of an oncologist. The oncologist recommended chemo and radiation. The patient preferred watchful waiting, much against the physician's recommendations. The physician had him sign a consent refusal and put it in the medical record. The patient died. The family sued. Doctor, you knew my mother needed chemo and radiation, but you chose not to give that to my mother. Well, we got the notice of intent, we pulled the medical record, and sure as heck, there's a consent refusal in there. And it stopped the case dead in its tracks. So I don't know if you use consent refusals right now, or if your consent even has that line on there. I would suggest you go back and take a look at it. It's usually just one line, but they have to initial it and then sign and date the bottom. Very important to have. My advice.
Excuse me, so on a regular consent form, that would just be another little mini paragraph on the consent form?
If it's on your consent, it's usually just one line, and it's about 3/4 of the way down, closer to where the SIG is. So if you're thinking of adding it to your consent, I would put it after all the information. So I'm reading about this procedure I should have, and the risks and benefits, possible complications, and then there's a couple of lines down, or maybe a paragraph, and then you see, I understand the procedure that my physician has recommended and explained risks, benefits, and complications to me, and I choose at this time not to have the procedure. And they initial and sign and date the bottom, give them their copy, and if you have electronic medical records, scan it in.
So at that point, they have to have known that they're not going to go ahead, right? Like if they're in the office getting counsel, a lot of patients are like not sure, but I guess this is specifically at that point they know they're not going to go ahead.
Now and some patients will ask to bring the consent home and bring it back. I would advise not to do that because you never get it back. And you don't want to go forward without the consent. So if they're not sure, allow them some time to sit and think about it, or call their wife, etc. But if they refuse, if during the discussion, the consent discussion, they say to you, you know what, doc, not for me, say, well then, I need you to sign this because my job is to take care of your eyes, and this is what I'm recommending, and I need you to sign this that you are choosing not to do what I recommend.
So there's that other situation where they counsel, they are not sure, they go home, they think about it, but then they never end up doing anything. So I guess to still get a consent refusal, you need to follow up with them, send them paperwork, and then send back.
I wouldn't do that. So, and that obviously can happen and does happen. That's when you pick up the phone and you make a call to the patient. And you document that call in your notes that patient has decided on this date and time not to go forward with a recommended surgery. And then whatever your recommendation is, please come back in 2 weeks or a month so we can re-review this. Please call me at any time. But that documentation that you picked up the phone and spoke with them also speaks volumes, because it's at that moment in time, because lawsuits can come in a year later, right? You won't remember that conversation. You may not even remember the patient. But when you look at the medical records, it will speak for what you did at that time. Take credit for what you did.
Staff could have that same conversation.
I wouldn't have the staff do it. This is a responsibility of the practitioner that you cannot hand off to anyone else. Consent. Yes, Dr. Irvine?
Randie, so along that same line, in a busy ophthalmology practice, there's a lot of education going on outside the physician's own individual purview. There'll be people who, surgery coordinators will come in and go over the procedure. Maybe some residents or fellows are going over it. What's the relative role for those individuals in that process, and what advice do you have?
Well, if you're talking about consent, they would have no role in that. That's your responsibility totally, is the consent discussion. They can support the consent discussion. They can do the surgery scheduling. They can tell them how to prepare for the surgery, your fellow can tell them how to prepare, what to expect afterwards. But that consent discussion is yours only. Yes?
So rather than an informed refusal, where
Medical record, right?
A clause that a physician writes in and just says the patient has now refused this procedure, even though we had a discussion of the risks and benefits, and this is what the patient.
That's absolutely fine. I would add a little bit more to it on the plan moving forward. So, and Howard can talk to whether or not that documentation will hold up in court. I would think that it's not going to hurt you. It will only help you. But if you're documenting discussion with patient, risks, benefits, and complications of the surgery, discuss patient has decided not to have the surgery now, patient to follow up in 1 month. Your plan has to be, okay, they've said they don't want to have the surgery, what do we do now? So is Howard, the documentation like that, can you defend that?
I'll talk about it, and yes, I can defend it.
Okay. All right. But it's so important, consent and consent refusal. Let's talk about when things get really serious with your patients, okay? And I'm not sure if those specialties are represented here where the patients are truly very ill or you can't do anything more for them. And this is where you as a person needs to come out. Your empathy, sympathy, gentleness, softness, time that you're not feeling rushed with the patient. And that's when you are actually the medicine. Because we all know that we don't always have the answer. We don't always know why this patient is having this type of problem with their eyes or with their vision. You could have all the degrees in the world and not have an answer. This will speak volumes to your patient. You need to listen. And you need to look at your patient, because what they're going to say to you and speak in volumes may not always be in words, right? It will be in their body language. Watch their family, watch their wife, watch their partner. Listen to what they're not telling you and give them the opportunity to talk to you. this will do more for the patient at that point than you could possibly say, I'm so sorry, there's nothing more I could do for you, but I will always be here for you as your physician. You have my number. Come see me if you need to. Talk to their partner. Call me if you need me. I'm always available for you. And even if you can get someone on your team to provide them with resources once you get to this point, it does speak volumes on the physician-patient relationship. Someone wrote this, and I can't even get it any better than this. I'll let you read it. So your patients can request a copy of their medical records. You may never know about it, and you don't know what they're going to do with it. It's their medical records. They can take it anywhere they want. Be careful what you write in your medical record. I'm an old proponent of the SOAP note. That's telling you how old I am. But electronic medical records make your life very easy and make your life a nightmare, if I'm not mistaken. Make sure you hit all of these bullet points. Absolutely your plan. Follow up if necessary, communication. I'm sure Howard will talk to meeting with a physician client and having the medical record in front of him and probably shaking his head going, oh my God, what were you thinking? I can't tell from your notes. What were you thinking? And you can't remember because it was over a year ago, and it's a blur of patients in a year, and maybe I was going to do this or maybe I wasn't. So the medical record is speaking for you. Make sure it informs, updates, explains. Make sure, of course, you always control pain because that's another buzz phrase that all the physicians are dealing with. Is it helpful or harmful? Do not cut and paste. I can't even tell you how many times we've looked at records that look the same. As a matter of fact, we just sent a record out for peer review, and it came back from the outside reviewer and said, interesting to note that the last 9 notes all are exactly the same. Cut and paste. Please review your previous notes, and then if you're in the hospital or if the patient saw one of your another physician in your group, please just look at the notes ahead of time. If it was important enough to write down, it's important enough to read. Patients have a lot of ways to say things about you now, right? Facebook, texting, email, Yelp. If I get one more Yelp, I think it's so passive-aggressive, but risk managers have a dark side that we go to sometimes, and it just makes me crazy. But I'm assuming that your email is encrypted. Maybe you have a patient portal that you use. Do not text your patients if it's not encrypted. Be careful what you put on email. And let me tell you about patients in email. If you are emailing with your patients, guess where they expect you to be the minute they're emailing you? In front of your computer. So if you don't get back to them for 8 or 10 hours, now they're really angry. So you might want to put a disclaimer on your email that you only look at your emails on such and such a time every day. Patient portal, whatever your organization has set up. I think the patient portal is great till a patient starts abusing it. And we have one patient that's doing that right now, not only communicating to the physician about a dozen times a day, but she's also doing it for her children and her husband as well. Yes?
On the email side, our email is encrypted,
Mm-hmm.
but, not everyone is. And then oftentimes the referring is not. That's not okay. That's okay, but I don't know. There was a relationship that was built initially.
So the referral physician that you're sending your patient to is...
Let's say someone's sending me, I'm sending them a letter. Well, I'm communicating with them.
Okay, all I care about is you. So,
I'm encrypted, they're not encrypted.
they should be.
Probably people still are not.
Possibly the physicians in private practice. Let's hope their risk manager is working with them. But if your information is encrypted, that's protecting you.
But you put the send button, and you send it to someone.
It's still encrypted. Yeah. And maybe Howard can talk about that. But, you know, if something is making your stomach hurt or the hair on the back of your neck stand up, take 5 minutes, step back, call the physician, you know, and let them know that you're uncomfortable with patient information going back and forth through email. But if your organization or your practice is encrypted, you know, that means you're HIPAA compliant and you can send patient information. The patient portal sometimes makes me crazy, only because patients don't really understand, and a lot of the organizations don't allow everything to be on the patient portal. So patients can't see everything, even though they think they can, and they start to argue. And then, of course, you have, do you see pediatrics? Anyone here see pediatrics? Okay, so there's a whole issue with a patient portal between the ages of 12 and 17. So, was there a question over here? No? Okay.
Hey, Randie?
Yeah.
Just on the point of Yelp, you know, this is just going to continue to grow, this online issue, and Yelp being the one that tends to always.
So can you speak up, Mr.
Yeah, the whole online review issue with Yelp particularly isn't going away, it's getting bigger. And Yelp tends to be the one that comes up on the first page for physician names typically. And just to share my experience, we've had a negative review. If it's a real patient name, I'll call the patient.
Yep.
Try to talk to the patient. And sometimes that can get a resolution for them to take down the review. And otherwise, because they're obviously unhappy, offering some sort of reimbursement or refund in exchange for a release, including that, getting removed, usually resolves the situation.
So this is a two-parter. So if you're able to figure out who that patient is, and we do it at my organization also, we do reach out to them and try and fix whatever was broken. As far as reimbursement, that is an organizational or business decision. Be careful, don't refund copays. That's a contractual agreement with the insurance company, and that can get you in a whole lot of trouble. If you are going to give them a financial settlement, absolutely have a release signed. But most important is the communication piece. If you're able to figure who that person is, you know, give them a call. We had an issue when I was at USC of horrible Yelp postings, and we found out it was an employee who was a patient at USC, and I made a little visit to him and offered for him to get his health care elsewhere, and they stopped. But I think it's very passive-aggressive. I'm sorry, I have a hard time with it. If you have an issue, speak to your practitioner, speak to the office manager, speak to someone, but don't post it, because a lot of it is usually garbage, and it's hard to defend yourself. Yes?
Last time I checked, I think the positive ones are all employees too. They're all employees, the positive and the negative ones.
Welcome to my world. I mean, it's hard to work with. So email, like it may one day be read aloud in a deposition. We're getting new subpoenas for medical records, and Howard, I'm sure, will support me on this. And now they're saying all information, texts, emails, you name it, they want it. Especially if a patient says, well, I have emails from my doctor. Guess what? You better have them too. So be careful what you put in email. The time is always right to do the right thing. As a risk manager, I always deal with a situation which is do the right thing at the right time for the right reason, and will be able to keep you safe. Remember, information is giving out, but communication is getting through to your patients. Any questions? No? Well, Dr. Irvine.
Can you comment on your experience with medical records that have incomplete notes or notes that haven't been completed in a timely fashion? Do you have enough time?
Finish your notes and sign them. You never know when a patient is requesting a copy of their records. So they'll get a copy of records that won't look like the one that you have with your attorney. And Howard will tell you it creates such chaos that your credibility goes down the toilet. You must sign and finish your note within the period determined by your organization while your memory is still fresh, and so you can get paid for what you did, by the way. But please, you must do it. If you can't do it immediately, then as close to immediately as you can. Yes?
Really appreciate your presentation. I was just curious when you talk about dance, like, nobody needs a mic for me, really. But I do neuro and plastics in Southern California, and when you talked about dance like no one's watching you, sometimes we have patients with unusual affect or something like that. And of course, you never know who's requesting your medical record or whatnot. You don't want to hurt anyone's feelings, and you don't want somebody to call back and say, what's unusual affect mean? But I didn't know, because it is your assessment. And so, or they're asking really unusual questions or something, and I just don't know how to navigate that whole thing.
We get that question in risk management a lot. Patients will get a copy of their medical record or go through the patient portal, and there'll be things in their medical record that they object to. Usually it's reference to alcohol, drug use, depression, similar to what you're talking about. Most organizations understand that patients have the right to request for their medical records to be amended. You as a practitioner have a right not to amend them. But that being said, be careful what you write, and it's always being objective. Usually it's because the patient told you, so then your note would say, patient states is seeing a psychiatrist for ongoing depression. But we did have, just a second, Dr. Sudhin. We did have an issue at USC, a patient who was in the legal profession and had been an alcoholic 25 years ago. Well, guess what keeps coming up on the problem list? And she demanded that it be taken out. And I think when I left there, they were still arguing about it. But if you're objective, and if you say patient states, I think you'll be okay.
I think that's fantastic.
Yeah.
That's a cue to everybody, hey, look, this is an unusual comment, but you're just repeating what they said.
Uh-huh.
So that's reasonable.
And we also, we have some issues sometimes with patients being a bit volatile and verbally abusive in the office. And the physician's notes, they usually send me the draft before they finalize it. They have to reference that, because if I'm going to discharge that patient from the practice, guess who's talking to the health plan? It's me. So we need some reference. I don't need that he said the F word 12 times, right? Which sometimes the physician will be very graphic in their note, because that's what they think I want to see. But I do need to know how the patient stepped out. I need the rationale on why I'm going to discharge the patient from their practice. It's because of this. Yes, Dr. Stu.
So, my view raises a very important point, and you gave an excellent way of getting around it, which is to put quotation marks when you can.
When you
but
can.
often you can't. You are making a psychiatric The number one point here is the records are not to be read in deposition or court. They're to communicate to yourself so you and other physicians can give the best care possible. An unusual affect is a critical piece of information for neuro-ophthalmologists to have in the records. My advice is go ahead and say an unusual affect or flat affect. Just don't put a value on it. I think that the patients would be very upset if you said this patient was annoying. But if you said this patient had a flat affect, they may not like it, but without the value judgment, it'd work. But you gotta have it in there. You need to remember a year later that they had that.
And also pull it together. Why did you comment on that? What did you feel that during the discussion you weren't getting through to the patient? So what value is it to the visit for that day that's important for you to document it in your note as part of that? And I think the fact if the patient says that they're seeing a psychiatrist, or even what else could clue you, you're looking at the medication list. The medication list is a great clue for you as well, for you to say, oh, I see you're on, do you currently see a psychiatrist? Are you feeling better? And then you can incorporate that into your note.
But part of what Madhu is saying is that the history, especially in your office, is so key.
Mm-hmm.
But we have to have, as a coefficient of the history, how reliable is the patient as a historian. So that is not going to be quotation marks. That has to be a place where we're saying, take this history with a grain of salt. Now, you're not going to say that. You're not going to say the patient probably is leaving a lot of key elements, but you have to put a clue in there that tells you to undercut the value of this patient's history.
I agree. Anything else? Yes.
Quickly back to the informed refusal, about the informed refusal. So if the patient refuses the treatment and they feel it's necessary, let me just give you an example. I have a nice lady, she has narrow angle glaucoma and she needs an LPI, a laser iridotomy, but she refused. She just doesn't trust laser or surgery or anything. She doesn't want that done. But she still wants to be followed and just have her eye pressure checked. And she was just saying, you're not gonna, discharge me or anything. I just want to check. I don't want anything done. So if you give them the informed refusal, is that enough? Do you still continue to see them, or?
So there is two avenues of thought on this. If your specialty is surgery or procedure, she's not appropriate for your care anymore, right? If she just wants her pressures checked. If you see other patients and you do other types of care, yes, but I absolutely would get the consent refusal. I mean, I would want to be able to maybe talk to her family members or whatever if she ever brings anybody in, or if not, and if she's adamant, no, I just want you to check my pressures. Of course, I'm not sure what you would do if the pressures were too high, what your care and treatment would be, but it sounds like it's heading towards disaster to me.
I mean, I told her, if you get like acute angle closure, and you go blind, that could happen. And she said, well, I'd rather go blind and have the surgery or laser.
Okay, so right there, I would have documented that piece and had her sign the consent refusal and give her a copy. And if you're okay to keep seeing her just for pressure checks, that's a decision for you to make for your practice. I mean, it sounds like she likes you and you have a good physician-patient relationship, except she doesn't want you to operate on her. But okay, so that's her, right? So it's up to you whether you want to continue seeing her or not. If you're a surgeon and somebody doesn't want surgery, why would you continue seeing the patient, right? But if you're okay with providing that limited care for her, I would document that and get the consent refusal. Anything else? Well, thank you very much for inviting me.